I'm going to talk a little bit about how to implement tomosynthesis or digital breast tomosynthesis into your practice. Again, like Dr. Budovec said, I'm Julie Sullivan. I'm from the Medical College of Wisconsin. It's where I did my residency. It's where I did my fellowship. It's where I chose to stay. But the good news is that we've got a lot of new technology. It's a different medical college today than it was definitely when I started residency, probably even when I started fellowship. So it continues to evolve. I have nothing to disclose. So I'd like to spend the next 45-ish minutes talking about implementing tomosynthesis into practice. There's a whole host of things to think about when you're considering implementing this new technology. There are several challenges that radiology groups face when they want to implement a new technology. We'll touch on several of those. I'll show a few sample digital breast imaging protocols, and we'll end with some lessons learned from our institution. Now, I do have a couple cases kind of dispersed between the talk as pertinent. Just so I could have a little bit of background about you guys, since you know a little bit about me, how many of you are breast imagers or read and interpret mammograms? Show of hands. Great. And how many of you are not currently using tomosynthesis in any way, shape, or form? Okay, just a few. And are you planning to in the near future-ish? Okay. How many of you have partial tomosynthesis, meaning not all of your patients are getting tomo, but you have tomo and you're using it regularly? Okay, most people. And how many have transitioned to a complete tomosynthesis practice, every patient screening diagnostic unless she declines? Okay, so we've got a mix of people here, which is great. Pretty much echoes the country. So a little bit of background about me and my institution where I came from. We got our first tomosynthesis unit in March, April 2015. This is just a little, oh, you can't see my cursor? Oh yeah, you can. This is just a little timeline here. So we got our first unit in March. By the time it was FDA approved, it was April. We were actually approached by a different vendor asking us to please trial their system in July, August. So we actually had the unique opportunity of having 3 to 4 months of 2 different tomosynthesis vendors at our institution side by side. This allowed us to really compare the nuances about each different system and their implementation. I think we thought probably a lot more about all these little various factors: radiation dose, usability of the machines, image quality, whether or not we just liked it, what kind of overall gestalt of 2 systems side by side. We eventually had to give the trial an end, so we chose the vendor that fit best for us in October of 2015. We phased out the other tomosynthesis unit and we acquired a second of the unit of our choice in April 2016, and it's been a snowball ever since. We got tomosynthesis guided biopsy capability in June, and we've exponentially added digital breast tomosynthesis throughout our health system, including 2 community hospitals and multiple outpatient imaging centers. We currently have, I think it's either 12 or 13 tomosynthesis units. So that's me. Throughout the talk, I'm going to refer to digital breast tomosynthesis as DBT, tomo, tomosynthesis, 3D mammography, 3D, just kind of whatever comes out. That's all the same thing. Contrary to popular belief, or not popular belief, it's not truly a 3D image. I have had people ask me if I have to wear special glasses to interpret the study. I'm not kidding. Thankfully, these people were not my radiology colleagues. But it's not a CT, so it's not true 3-dimensional image. We'll get into that in just a minute. It is FDA approved. It's acquired either in conjunction with or in place of a 2D mammogram, and really it adds a few seconds to the patient experience. So various vendors have all created different solutions to how tomosynthesis works, but essentially they all do the same thing at the core, kind of dumbed down to my level, where they acquire a series of low-dose exposures at varying angles, and these individual source projection images are then reconstructed into a series of thin, high-resolution slices, which are typically about 1 millimeter thick. And these slices can be displayed, you can scroll through them, or you can view them as a cine. And really the benefit is tomosynthesis gives you a 3D-like look through the breast, which minimizes the effect of overlapping tissue. So in the case of breast cancer diagnosis, it could unmask a cancer hiding in dense tissue. And conversely, if you're questioning an asymmetry, you can scroll through the tissue and see that it's not actually anything, it's just normal breast tissue. So I'm not here to sell you on tomosynthesis. I'm assuming everybody has already heard about it, and everybody who doesn't have it is thinking about potentially implementing it. So just so we're all on the same page, Major studies, including those in the AJR and JAMA, that are well publicized, have shown that DBT detects significantly more invasive cancers than 2D alone, which is increased sensitivity. It has not increased our detection of calcifications compared to 2D alone, which calcifications commonly present is a common presentation of DCIS, which is the in situ cancer, owing back to that overdiagnosis we just heard about. It does reduce the false positives for pseudo-lesions or areas of fibroglandular tissue overlap that are predominantly non-cancerous, so improved specificity. Reductions in recall rates are quoted anywhere from like 10 to 42% in the literature. And the initial studies were done as DBT in addition to 2D, but subsequent studies have shown a benefit to just the tomosynthesis acquisition, including synthesized 2D images, but without a 2D exposure. So DBT has also been shown to improve our positive predictive value for recalls and biopsies, but it's not perfect. It's still a screening modality. It does not do away with all recalls, and it does not do away with recalls for things that aren't cancer. So now let's get into kind of the meat of the talk. That's the background of the what and why. Now let's get into the how are we going to do this and what do I need to think about. Even if you've already got tomosynthesis at your institution, these issues are not one and done issues. They often need to be revisited as you're working through your implementation. The first is that we'll talk about, and again, in the interest of time, I'm not going to talk about every single one of these, but we will spend several minutes touching on the basics of things to consider in these topics. So required training, there is new modality training requirement which applies to all mammography personnel, anybody who's going to be involved, radiologists, physicists, technologists. In addition to meeting the MQSA mammo requirements of 8 hours of dedicated tomosynthesis training prior to clinical implementation, all personnel must receive 8 hours of dedicated tomosynthesis training. This used to be dedicated vendor specific. So when we had our trial, we had to do 8 hours of one vendor and then an additional 4 hours of the other vendor. But the FDA has since revised that and said training in one or generic training for DBT will suffice. Residents and fellows can get this 8 hours during their training as long as it's documented in the letter by their program director. So the next thing you need to think about is equipment or financing. There are currently 4 FDA-approved tomosynthesis options. Hologic was the first one to the market for FDA approval in the United States in 2011. GE followed in 2014. Siemens was FDA approved for digital mammography in 2015, and Fujifilm newly joined the ranks in the United States in January of this year. So with equipment comes cost, right? Got to think about how many units are you going to need, at what time frame. Can you replace all of them all at once? Is it going to be a rolled staged procedure? And another thing to think about is that several of the vendors have proprietary dedicated mammography viewing workstations, which also come at an additional cost. So for us, in our reading room, we have 2 diagnostic radiologists, plus fellows, plus a screening radiologist. So we would need like 7 or 8 just at our mothership reading workstations, which would add to the cost of whatever you're considering. It's really tough to get an accurate quote on a single unit just by cold calling, but a new unit with DBT capability runs about $750,000, and my understanding is just the add-on, if you already have a 2D unit, to add on the tomo capability is about $370,000. So nothing to shirk at. Piggybacking on budget and equipment is really the question of resource management. It may not be economically feasible to replace every 2D system with a tomo-capable unit right away. Most likely, you'll need to undergo this implementation in phases, right? Beginning with 1 to 2 units, and then when you are implementing it, your unit goes down for a day or 2, and then you have to wait for FDA approval. So you have to consider all of that in your timing. And once you have DBT, really you need to develop criteria for determine which patients are going to get tomo, this new technology, and which aren't, until you have the capability where every patient, every time, is offered this. There are many ways to do this. I'm going to tell you up front, there's no right way, and I don't have a right answer. But we can talk a little bit about ways to do it, and at the end I'll show what our institution chose to do. So you can choose random, first come, first serve. If you show up for your screening appointment and the tomo room's available, great, you get a tomo. You show up 2 minutes later, the tomo room's taken, sorry, you're getting a 2D mammogram. You could do it by patient preference or insurance coverage or ability to pay. You could have some sort of statistical calculation of lifetime risk of breast cancer and offer it only to high-risk women as an adjunct to screening. You could stratify women by breast density, or you could choose to do it by exam type, all diagnostic exams or all screening exams. There are pros and cons to all of these. I'm going to talk just a little bit about breast density and exam type because I feel there are some lessons to take home from that. So the benefits of Tomo can be seen across all breast densities. Make no mistake, all breast densities. They are especially useful for cancer detection in denser breasts, right? Heterogeneously dense, extremely dense. The combined use of DBT with digital mammography is also associated with improved outcomes, not just for screening, but also for diagnostic imaging. If you have to cut some patients out, the low-hanging fruit are the patients with comorbidities, medical comorbidities, movement disorders, tremors, limited mobility in a wheelchair. Because the acquisition of the images is sensitive to patient motion, especially as your technologists are training and getting up to speed, these patients are not ideal candidates for tomosynthesis in the beginning. But again, stratifying who gets this limited resource is not straightforward. It's expected that it makes sense intuitively that dense breasts have more structural noise, there's more fibroglandular tissue than fatty breasts, so yeah, being able to scroll through that should be able to help me detect more cancers. But again, clinical data supports that it performs better in all breast densities, including fatty breasts. So what happens in fatty or scattered breasts is that there can be subtle areas of really low contrast distortion that your eye can just overlook on the 2D mammogram because there are confounding areas of low contrast glandular tissue or Cooper's ligaments that can look the same. So having the 3D can show more invasive lobular and architectural distortions. On the flip side, on the other end of the spectrum, in extremely dense breasts, you may not have enough fat to give yourself a fat glandular interface, so there are still cancers that are undetectable by digital breast tomosynthesis. But overall, Tomo increases the conspicuity of lesions, particularly distortion and masses, and not only is it increased sensitivity, but increased specificity, meaning you're able to talk yourself out of asymmetries and focal asymmetries, either because they go away on the 3D, or you can use the rule of multiplicity. There are several similar appearing asymmetries in both breasts. These are probably not a cancer. So I've got, this is a case, heterogeneously dense breasts. You look at the 2D mammogram, you're kind of like, meh, nothing's really jumping out at me. But we'll play the Tomo here. And I don't know if you guys saw that. We'll scroll it one more time and we'll turn on the MLO. As you're scrolling, you notice, there's a little delay here, huh? An area of architectural distortion just kind of comes to your eye. And here are the synthetic views. And you can really see, I don't know how to, there we go, the architectural distortion, and even on the MLO view, because the synthetic mammogram also can help bring this to your attention. So that's a heterogeneously dense breast. Here's another breast. Some people may call this fatty, some people may call it scattered, there's a little bit of subjectivity to it, but regardless, it's less dense than a heterogeneously dense breast. You look at the 2D mammogram and you may or may not appreciate the abnormality depending on how long you look at it and what all the factors, the light in the room, if the resident's talking to you. But let's play here. And there you see in the medial right breast at anterior depth. Is that working? Hello? On the MLO view, and I'll scroll the CC view just one more time. I don't know if you guys all had a chance to catch it. So there's an area of architectural distortion here in this fatty breast. This is what it looks like on ultrasound. Shocking that something that big can be hiding, right? So breast density, it's good for all breast densities. If you need to stratify, it is better for denser breasts. Another way to stratify patients would be screening patients or diagnostic patients. Tomosynthesis has been shown to expedite diagnostic imaging workup. It reduces the number of images needed. For screening recalls, oftentimes the full field views really delineate the margins. They can help with triangulation, so you don't need rolled CC views. You already know it's in the superior half of the breast. You often don't even need the true lateral view. Actually, our facility just gave up the true lateral view. For triangulation of findings on the MLO view only. You don't need tangent views for things in the skin. So really, that saves on the imaging, but in addition, studies have showed similar or improved performance of DBT only in the analysis of lesion margins compared to spot compression and spot magnification. I say lesion margins. Magnification views, 2D magnification views, are still needed for calcifications. As of right now, you cannot do magnification with tomosynthesis. Another thing to note for diagnostic imaging is that if you do see a tomo-only cancer on the full field view, sometimes if you do a 2D spot view, it looks like it goes away, but don't be fooled. And that's why, you can't really overrule a tomosynthesis finding with a 2D spot compression view and a negative ultrasound. DBT has also been shown to be superior to 2D in predicting tumor size, demonstrating tumor margins, and extent of lesions and staging. So this is a real eye test, right? You're on the first slab and everybody can already see the cancer. But I think this case illustrates the point that it's not hard to see the cancer, but where tomo shines is that it really helps you define lesion margins. You don't need spot views. You can measure tumor extent. You can really see those spicules. Here I've got, these are just slab. So I created some thicker slabs so you could see the tumor, and you can really see these spicules extending all the way. This is a T2 tumor. And actually, as you're scrolling through the tomo, you see these nice, normal-looking axillary lymph nodes with big central fatty hyla. So that's one of the benefits of tomosynthesis for the diagnostic imaging setting. So she only needed 2 full field views. She did not need spot views to define all of that, and she's staged. Other studies have shown that DBT for diagnostic imaging actually allows for more definitively BI-RADS 1/2 or BI-RADS 4 characterization. So it reduces this middle, probably benign BI-RADS category. This study actually quotes up to 50% compared to standard 2D mammography alone. Probably that's related to multiplicity. You see multiple similar appearing findings, and also increased radiologist confidence and asymmetry on a baseline mammogram that looks like nothing on tomo with nothing on ultrasound may just be nothing, so BI-RADS 1-2. And that could lead to a shift to a greater proportion of back to screening instead of following up these patients over time. This is a case of a woman who came in, I think it was for breast pain. She had priors, we just didn't have them when she showed up. She'd had a prior breast reduction, which is why her breasts look funny. So you see this asymmetry in the lateral right breast at middle depth, and you're like, what is that? I wish I had comparisons, but her comparisons aren't there, but she thankfully had a tomo exam. So as you scroll through the tomo, you see that it's just a little vessel curlicuing on itself. BI-RADS 2, maybe BI-RADS 1 if you choose to just ignore it. Don't need to spot it, don't need to ultrasound it, don't need to do anything. So how did we choose? We have so many options of how to stratify patients. At our institution, we did have to do like a phased rollout, so we felt that with a limited resource, screening mammography would maximize the number of patients who could benefit from the technology because it takes less time than a diagnostic exam. And in addition, the benefit of the reduced recall rate is really only seen in the screening population because our diagnostic patients stay until the completion of their appointment. So not recalling women for additional imaging is really only going to be beneficial in the screening setting, the way that we practice. We also felt like getting the screening volume would allow the radiologist to see the variation in normal and benign, kind of learn tomosynthesis, and increase our speed at reviewing the images. So it was offered to all patients, and it was performed by a patient request, essentially. It quickly became apparent, like I touched upon earlier, that screening detected findings with tomosynthesis could not be overruled by a 2D diagnostic imaging workup. So then we were in this conundrum. You saw something on the tomo screening, you don't see anything on the 2D, and you don't see anything on ultrasound. Well, now what? So we started doing diagnostic tomosynthesis studies per radiologist and or as requested by the patient or referring provider. Eventually, any screening exam that was performed as a DBT, if additional images were needed, they were also done as DBT. And we, in this phase, got biopsy capability. And we did have to actually shift our patient's schedule, right? As we started adding these diagnostic slots, we had to take some of those screening tomo spots, right? Because we didn't have unlimited resources of rooms. And now we had this backlog of screening patients wanting tomosynthesis. We had to extend our hours of service into the evening. So we offer evening screening DBT appointments to accommodate the downtime when we're using the tomo room for biopsies or for diagnostic patient appointments. Phase 3, we're not there yet, but complete conversion to a complete tomosynthesis practice. So next thing to think about when you're building your DBT program is radiation dose. So the cumulative dose for a single DBT view is similar to slightly increase that of a conventional 2D image. Each of the raw data is a very low dose projection image, so that cumulatively the dose is similar to a 2D exposure. Again, actual patient dose varies depending on breast size and composition, but the combined dose due to DBT is essentially equivalent to 2 months of annual natural background radiation. So in the grand scheme of things, it's minimal. It does vary a little bit by vendor. You know, initially, Hologic was FDA approved for 2D plus or minus tomosynthesis. So when you're doing the combined 2D plus tomo, that's 2 to 2.5 that of dose of a just diagnostic mammogram 2D. Then in 2013, with improvements in the synthetic reconstructions, the FDA granted approval for 2D synthetic mammography data to be used to replace the 2D mammogram. So performing a Hologic exam with CC and MLO DBT only with the synthetic mammogram called the C-View is about 1 to 1.5 times a dose of a conventional digital mammogram. Siemens is also FDA approved for a standalone 3D acquisition. They do not require the 2D exposure, and their single view DBT dose is quoted at 1.4 to 1.9 that of a single diagnostic digital mammography dose. GE is actually FDA approved for a 2D CC with a DBT MLO with a V preview, which is their synthetic mammogram. Their FDA approval says clinically not inferior to standard 2-view digital mammography. They did not show superiority. And several places that use GE actually still acquire the CC tomosynthesis sweep, right? Because oftentimes invasive lobulars are best seen in the CC projection. So if you're only going to do the 2D CC with the DBT MLO, you may miss those. So depending if you choose that vendor, some institutions have chosen to do the 2D CC plus the tomo CC plus the DBT MLO. And you can't skip the 2D CC because that's how it's FDA approved. So their dose is approximately the same for a DBT view as that of a 2D view. Unfortunately, I don't have much information on Fujifilm since it's kind of newer to the market, but more to come on that. Just to put that in numerical perspective, we all know the MQSA maximum allowable dose in a breast phantom that's 4.5 centimeters, 50% glandular, 50% fat is 3 milligray. So just to put that, kind of keep that in the back of your mind, a standard 2D digital mammogram is one view is about 1.2 milligray. 3D exposure is about 1.45. With that, you would get the synthetic view if you're using Siemens or Hologic, or even the V-preview on GE. I'm assuming Fuji has the same thing, but I don't know. When you combine the two exposures, it's 2.65 milligray per view, which is still less than the maximum allowable dose for an exposure. And just to put that in perspective, when those trials were done showing the benefits of screening mammography, the average dose was like 1.75 to 2.3 milligray per view. So it's confusing for patients. We initially were telling patients, oh, you may be exposed to a little bit of extra radiation, but it's well within safety standards, and patient would get confused and would cancel the tomosynthesis exam. So we've simplified our messaging to our patients to say that there is very little radiation exposure. It may be slightly more than a traditional digital mammogram, but it's well within FDA standards for mammography, period. All right. We've talked a lot about patient selection, radiation dose. We're going to kind of move quickly through the next things. Reading workstations, you need viewability. You need to be able to interact with your images, scroll through them at a rapid frame rate. It's nice to have autoplay cine so you don't get carpal tunnel. It's great to have co-registered images where the synthesized mammogram and the 3D are kind of co-registered, so if there's a finding you're questioning, you can problem solve by toggling back and forth between the 3D and the 2D or synthetic mammogram. You need to be able to view comparisons. You need to be able to annotate individual images and develop efficient hanging protocols. As I mentioned before, most vendors have proprietary dedicated mammography workstations. However, there are third-party PACS integrated solutions available, so look into that if you're interested, and potentially the PACS that you're already using has a mammo upgrade. PACS storage, this is no joke. When I was a resident, I was like, oh, that's like the techie side. It doesn't really matter, but it really does matter. So when we talk about storage, we're talking about both server space as well as short and long-term imaging archiving. So if you're going to acquire a 2D plus a tomosynthesis data set, combined, that is 1 gigabyte of data. That's 100 times that of a standard digital mammogram, or 200 times that if you're saving the raw projection images, which some places save and some places do not. Of course, you can compress the data lossless 4:1, which would be about 250 megabytes, which is still nothing to sneeze at. Exam performance time. The images are basically the same as a 2D from the patient perspective. They're compressed the same, it's a few extra seconds, and it's done. So the whole thing is very fast. Patients don't really appreciate much of a difference. On the other side, in the dark room, for the radiologist, we do appreciate a difference. Initially, studies showed approximately double the interpretation time of a tomosynthesis study, screening study, compared to a 2D screening study. If you just think mathematically, you had 4 images to review before. Now you have the 4 images, plus assuming an average 5 centimeter breast, which we live in Wisconsin, so that's usually it's a little bit bigger. At 1 millimeter slices, that's 50 images per view, times 4 views. That's at least 200 images that we have to look at, plus the 4 full field views. So it does take a longer amount of time. Some studies quote that after you adjust to that increased time and kind of go up the learning curve, you can reduce that longer interpretation time to about 50% longer than a 2D view. But that increased time reading screening studies may be paid back essentially by fewer imaging recalls. So we all know that diagnostic breast imaging is conventionally a little bit more time consuming and relatively less financially compensated compared to screening. So it may not be the worst thing in the world to shift your practice towards more screening volumes and less diagnostic volumes, which would be good for financial reasons, patient anxiety reasons, and just workflow management reasons. So the other thing is, initially you don't want to start with reading 100 2D screening mammograms a day, have a couple days of downtime, and then the next day you have 100 tomo exams, because your radiologist is going to be there until midnight and they're going to be tired and unhappy, and it's terrible. So consider gradually gradually adding DBT appointments as your radiologist kind of acclimate. Several vendors are reportedly working on these clustered reformat displays, which could help decrease the amount of time it takes to review these images. Not only is there a learning curve with interpretation time, but there's also a learning curve just getting used to these images. Typically, when you implement tomosynthesis, the recall rate does go up a little bit. Some people say this is due to detection of DBT-only cancers, or like a prevalence. It's been there all along and we just happen to see it better versus incidence, right? So if they come back the next year and have the 2D, that would be incidence. If there's a new finding, if next year on their second tomosynthesis exam there's a new finding, that would be incidence, right? And really, the learning curve is setting this new operating point, which is challenging. Balancing your sensitivity with your specificity, and that takes some time, and they say about 500 to 1,000 tomo studies is where radiologists start to feel comfortable with their operating point. And with increased experience, obviously the recall rate stabilizes, and then eventually it will decrease, like we talked about, to 10 to 42% decrease in recall rate for screening exams. Billing and reimbursement. These billing and reimbursement rate values were created for DBT in January of 2015. They were updated in 2017. There was really no change to DBT billing, but for screening mammography in general, CAD was added, whether or not you use it. It's with or without CAD. So these new codes exist. However, it's still an add-on code. So the work RVU for TOMO is 0.6, which is added on to the screening code or the diagnostic code. So while we have these billing codes, insurance coverage still varies. Some insurances are considering DBT unproven and not medically necessary, but the ACR and several more advocate groups for radiology have said that this is no longer an investigational technology. One of the major challenges we faced was, how do we handle that with our patients? Do we charge them a flat fee? Do we tell them we're going to bill their insurance? Do they sign a financial waiver saying if their insurance doesn't cover it, they're responsible? Do we waive the cost? Do we give it free for everybody while we up our volumes and learn what we're doing? We really struggled with that, and there is no right answer. But as always, we tell our patients, you may be responsible for out-of-pocket costs. Please check with your insurance prior to the exam. This was a map actually distributed by Hologic last month in like an email they sent, just telling us that as of April 1, both Anthem and United, which are the two largest commercial payers, are now covering digital breast tomosynthesis. So this is Medicare. Oh, you guys can't see. So Medicare is kind of that blue color. Medicaid is the stripes. Other commercial payers are the dots. The plus sign is Blue Cross Blue Shield. So you can see in Wisconsin, we have some that are reimbursing for tomosynthesis. Interestingly, the insurance at the Medical College of Wisconsin does not yet reimburse for tomosynthesis, but we're getting there. We're making some progress. That kind of piggybacks into education and marketing. You need to obviously tell people about this new technology when you're having it. The breast care team, the radiation oncologists, the oncologists, the surgeons, the nurse practitioners, your referring providers, primary doctors, OBGYNs, the technologists, patients, work with marketing and third-party payers, as well as policymakers, to get this tomosynthesis approved. We found that actually physically meeting with referring providers helped. There were actually some primary care providers that told me to my face, oh, well, tomosynthesis is just a money-making scheme for radiologists. No, but here, let me show you some images. Let me show you why it's better. Let me show you why it's not perfect, why we can still be fooled, why you can still have a recall, even though it's a DBT study. But also, let me show you why it's much better than a 2D mammogram. And really taking that time to sit down with those providers, having a lunch and learn session has paid off. There are several resources. I'll direct everybody to the ACR DBT resource packet, especially if you're looking about building your program. They have lots of things up there. Unfortunately, their coding guidance is a little bit old, but I'm thinking that it's going to be updated soon, especially given the 2017 CPT codes. And also the Society of Breast Imaging has a really great website with lots of resources. And I'm a big advocate of the End the Confusion website, which has patient and provider friendly materials that you can just print off and use as well. So that was a lot of things you have to think about when you're implementing tomosynthesis. And as we were talking about that, we really touched on several of the challenges that arise when you're thinking about adding this technology to your program. The biggest one of the biggest hurdles is determining which patient populations are going to get this, especially when you have limited resources, especially initially. Then you have to figure out, time for a learning curve to interpret studies, not only for time to actually review the study, but also to recall, but also the learning curve for imaging recalls and the increase in diagnostic volume that you're going to have as a result of that, at least initially, until your recall rates stabilize and then decrease. You have to continually adapt your tomosynthesis practice. So since we had it, the FDA approval changed. So we've had to revisit our imaging protocols, consider radiation dose, make a decision as to whether or not we wanted to change our protocols, adapt continually, because this technology is continuing to adapt. Really have to work with our mammography team, our referring providers and patients. Actually, we've developed better relationships with our IT support. They've been up in mammography a lot more than they ever have in the years prior. And also dealing with inter-radiologist variability within a practice. What one radiologist sees on a screening mammogram and says, this is a tomo finding, I would go right to ultrasound. Well, when the diagnostic radiologist is a different radiologist who says, I'm not convinced, I guess I would like additional diagnostic views, then how do you schedule that patient? Do they have their ultrasound first? Do they have the diagnostic first? How does that work with your patient schedule? So coming up with some protocols that are a little bit standardized can really help mitigate that. So I'm going to show just a couple sample imaging protocols. Screening protocols, again, a little bit depends on the vendor and what they're FDA approved for. That's going to affect what baseline you can do, and then you can monkey with it from there. So DBT acquisition plus or minus 2D depending on vendor FDA approval and/or radiologist comfort. For a standard screening exam, we do CC and MLO tomos. We instruct our technologists that if it's a large-breasted lady and you need to tile, or if for any reason you can't get the whole breast on the field of view, then please include the fibroglandular part of the breast on the tomo exposure. If you need to do an XCCL, that can be done as a 2D exposure. For implants, we'll do the tomo with the implant displaced and a 2D exposure with the implant included. We are actually still acquiring 2D in addition to the 3D data set, but as this synthetic mammography technology improves, we may revisit that in the future, but we've talked to several other groups as well, and there are some places in Wisconsin and elsewhere in the country that have given up the 2D mammogram, but we still feel like there are benefits to having that 2D picture. In terms of diagnostic imaging protocols, really we've seen a shift in our diagnostic practice. We're decreasing the number of diagnostic images that are needed. Like we talked about before, you don't need as many spot views, you don't need rolled views, the only thing you still need is magnification views for calcifications. So if we recall a woman for calcifications on a screening mammogram, we're only going to do the spot mag views. You don't need any other views unless there's something else. For asymmetries that are seen on one DBT view only, we'll do a spot compression tomo view. If it's a clearly seen mass, we decided on a threshold of 7 millimeters or more, especially in a larger breast. You can go straight to ultrasound. But if it's a 4 millimeter mass in a big breast, then your colleague who's doing the diagnostic ultrasound is going to be searching and searching and searching. So sometimes it's helpful to have a little bit more diagnostic information, maybe a true lateral view, because although tomosynthesis is great at localizing things, it's not perfect. So if it is not clearly seen in 2 views, we will do spot compression views, sometimes adding a true lateral. For all diagnostic imaging, we start with just the 2 full field views and go from there. And male patients do not get tomosynthesis unless they specifically ask. So, all that being said, that's a lot. Let's talk, just ending with some lessons that we've learned at our institution. Number 1, if you build it, they will come. Actually, that's not true. So, these are our screening volumes. This is a snapshot. We did start in March of 2015. However, we did not have a separate exam procedure type for tomosynthesis, so I have no way of tracking those tomosynthesis exams besides a manual process. So this kind of digital process starts in March of 2016 when we started coding bilateral screening mammogram with tomo, or right breast screening with tomo, or diagnostic with tomo, separate from our regular one. So you'll see, a year in, we still have pretty low volumes. And then it kind of starts to increase, and actually last month was the first month where tomosynthesis screening surpassed our 2D screening volume. This is our overall volume up here, so pretty constant, maybe a little bit increased. You do see that kind of end of the year bump, right? Everybody gets their screening mammogram in by the end of the year. So we did get our second unit in about April 2016. Community hospital got their unit about May, June, and then we've since added so many more images, and look at what that does to our volumes. Diagnostic volumes, again, our phase 1 was screening, so it's not unexpected that our diagnostic volumes were pretty low to begin with, but they have increased almost linearly over time, and our 2D diagnostic volumes are kind of comparably decreasing. Not yet surpassed, but I imagine if we go out April, May, June maybe, those lines will probably cross. So where were all of our tomo patients for the first year? We did not do a great job advertising to the public, to our patients, or even to our referring providers. We did not have buy-in. As I said, we physically met with several referring providers to just tell them about this technology and why we're saying it's the best thing since sliced bread if they don't even believe in screening mammography. Another interesting thing with a meeting with the technologist, we found out that our technologists had some misperceptions about tomosynthesis and were telling patients, oh, you have fatty enough breasts, you don't need tomosynthesis. So really educating everybody, your technologists, your schedulers, when the patient calls and asks a question about the tomosynthesis exam, making sure everybody who's going to talk to the patient understands the radiologist's perspective and is able to kind of present the information that should be presented to the patient. And we also struggled with billing and reimbursement, and initially we had patients sign a financial waiver saying they would pay, which deterred many patients from having this technology. But that's kind of all been sorted out with the CPT codes, etc. So lesson number 1 is not true. Actual lesson number 1 is education and outreach is key. You need to talk to your patients. Take that opportunity when you're one-on-one with them to answer any questions they may have about screening mammography or tomosynthesis. Market mass to the mass population, right? You take advantage of radio, newsletter, websites. In your facility, have information out in the waiting room so patients at least are aware that this technology is there and they can choose to learn about it or not. We had in October, which was Breast Cancer Awareness Month, I noticed it was in all the elevators throughout the hospital and the cancer center and everywhere. There was just like, oh, consider tomosynthesis. You're not pushing it on them, but you just want them to be aware that it exists. And if they have questions, direct them to resources. Make sure your facility website is up to date, and also providers, as well as all of your breast imaging staff. Because patients will say, well, my neighbor's sister's daughter had breast cancer and was told that her tomosynthesis exam cost it. Well, I don't know where that came from, but the more people you reach with your message, the more people who will understand the value of this new technology and why we all are trying to adopt it. Again, these are the same resources as before, but you don't have to start from scratch. A lot of this work has been done already, so if you need resources for your patients or providers, look here. Lesson number 2, really experience is the real teacher. Those 8 hours of required training are nice, they're helpful, but your first tomosynthesis exam, you're still gonna be like, you need that real world, real reading experience. Adjusting your eye to that synthetic mammogram takes time. It's not the same as a 2D mammogram. And then there are a host of DBT findings that are a little bit different than on 2D mammograms, and figuring out how best to handle them can be a challenge. So we all know the benefit of having a full field 2D or synthetic. I'm gonna call synthetic SM, so don't confuse that for screening mammogram. So the importance of a full field 2D or synthetic mammogram is well recognized, helps you compare to prior studies, and also it really helps you perceive calcifications. It does take getting used to. The technology is improving, but studies have shown that the generated 2D images alone or in combination with DBT are comparable to standard 2D alone or in combination with 2D. That's a powerful statement. That says you could get just the C view or just the C view or Inspire view or V preview, although I don't know that GE was involved in that, but you could do just the synthetic images compared to a 2D alone without any tomo data set, and that's comparable to 2D, is what this study is showing. So really, do you need that 2D extra 2D acquisition? Just a little bit to show you how technology is improving. You have that 2D MLO view on the far left, and the middle is what the C view looked like last year. So a little smoothed, harder to see. And then when the patient came back this year for her screening mammogram, actually, that's when I was like, wow, C view really is getting better, right? That technology is a little bit sharper, there's a little bit more contrast. Still doesn't quite match that of the 2D mammogram, but it's getting there, and it's continually improving. So maybe in the near future, we won't feel the need that we have to acquire the 2D mammograms anymore. And it's been suggested actually that for a first comparison, a new baseline tomo, you acquire the 2D plus the 3D, and then in following years, you would just do the tomo with the synthetic mammogram, which would be an initial increase in radiation for comparison purposes, and then you have the C view or the synthetic V preview or the Inspire and Siemens moving forward. So calcifications look a little bit different on the tomo exams. Large calcifications can cause artifact, we all know that. If they're big, bulky dystrophic calcifications at the lumpectomy site, sometimes that can affect your evaluation of the adjacent tissues in the lumpectomy site. And on the converse, if you have tiny little microcalcifications, it can be really hard for your eye to perceive that 2 here and 2 slices later and 1 more the next slice is actually a group of calcifications. So that's why, again, you need slabs or the full field views. And it's interesting to note that you can have calcifications or what looks like calcifications on the synthetic views which are not real. And this actually tripped up several of our radiologists when we first implemented this technology. So this was a patient. These are the synthetic mammograms. For whatever reason, she didn't get a 2D mammogram. The tech pushed the wrong button or something. And so the radiologist questioned these grouped fine calcifications in the superior right retroareolar region, which are not projecting very well. The patient was recalled. We did mag views. There's nothing there. So we couldn't reproduce that. So the trick is, if you see something on the synthetic mammogram, make sure you look through the tomal slices to verify whether or not there are actually calcifications there. Architectural distortion is better appreciated on DBT compared to 2D, which makes scar markers and patient history so important because you don't want to be biopsying or concerned about something that's post-op. There's emerging data on the significance of architectural distortion with and without a 2D correlate and with and without an ultrasound correlate. This one study published in AJR in 2014 said that a lack of ultrasound correlate usually indicates radial scar, typically. And another study showed that the malignancy rate for architectural distortion without an ultrasound 2D or even an MRI correlate approaches about a 50% malignancy rate. So the moral of the story is you still need to biopsy these lesions. Anecdotally, we've had an increase in tomo-guided biopsies for benign radial scar and complex sclerosing lesions. So this is a case of architectural distortion, which was really only seen, there it was, on the CC view. Couldn't see an ultrasound correlate, couldn't see, I think this is all we did. So we did a tomo-guided biopsy, it was a radial scar. Companion case, subtle architectural distortion in the left breast at 1 o'clock middle depth without a sonographic correlate. We did a DVT-guided biopsy, this was a complex sclerosing lesion. So what do you do with these when you don't yet have tomo-guided biopsy capability? That was a big struggle for us. If you can find it with ultrasound, you can biopsy it with ultrasound. If you have reliable landmarks, you can obviously do a stereotactic guided biopsy. We would recommend doing a tomo post-clip to make sure your clip's in the right spot. And the key is going to be to have a low threshold for biopsy discordance. If you don't have sclerosing in the diagnosis or something that explains the distortion, then it's discordant and it needs surgical excision. And if you can't biopsy it because you don't see it with ultrasound and you don't have reliable landmarks, then the patient needs to go to surgery, unless you have a scar or another explanation. All right, we're running short on time here, so skin findings, usually straightforward. Typically they're marked with a marker, or you can tell because they're outlined by air. But one thing that tripped us up, I think, initially is that it doesn't have to be on the most superficial slice. So the way the images are acquired, there are 5 extra slices added to the cranial and superior medial aspect of the acquisition, where because the breast thickness is variable, right? So the machine doesn't know if the breast is compressed this thin or this thin. So it adds extra slices. So skin findings can actually appear to be five slices in. And for a lot of people initially that was disconcerting because they expect it to be on the most superficial slice or two. But really, studies have shown, look for those caves of Copans, what we thought were skin pores initially, right? Those those little, let's see if we can stop this right at the right spot. So this is pretty obvious skin finding in the medial right breast. I don't know if we're gonna, So you're looking for, yeah, that's on there, great. These little black dots, which identify the skin surface. And when you see those, as long as the finding is there or more superficial, you know it's a skin finding, it's a BI-RADS 1. So, from our experience, don't be fooled by synthetic calcifications. Really, surgical history is really important, scar markers. Skin findings don't have to be on the most superficial slice, especially if they're cranial or superior medial. And false positive findings are typically benign looking things like a lymph node or a cyst that's probably been there all along and you just happen to see it better because of the tomo, and really struggling to reset your threshold to balance your sensitivity with your specificity and avoid recalling patients for these tiny little ditzels. IT, again, is important. We talked about you need to develop a system and an infrastructure. Make sure you spend the time to develop a hanging protocol that works. It takes a little extra time on the front end, but it saves you time and efficiency on the back end. You can choose to have CAD automatically display, or you can choose to add CAD, which is available for synthetic mammography as well as the 2D mammograms, regardless. And the CAD charge, as we know, is billed regardless of whether you use it. It's included in the CPT code. And again, choosing whether or not you choose to go with a vendor-specific workstation or a third-party viewing station. We have had issues throughout our implementation with slow loading of these PAC studies. You sometimes need to expand your bandwidth. Some technical workflow tips. Make sure you flag the annotated image. It helps your techs, it helps your radiology colleagues. If possible, also mark the area on the 2Ds, even if there's no actual 2D finding, because it helps your radiologist know right where to look. It helps your techs know if they're looking for landmarks to do any additional pictures or for follow-up. And we have found that integrated workstation was a solution for us because it enables us to view the MRI, the ultrasounds, all at the same time without having to get up and go to a separate workstation. So some other random workflow tips. Try and minimize the workstation environment. We actually found the disruptions were more bothersome once we implemented tomosynthesis because of the concentration that you need to scroll through these images. We had a little bunker created, like a hidden thing in the basement of the lab. to allow us to be uninterrupted to read, which really helped, especially while we were getting used to reading tomosynthesis studies. Some studies have suggested reading the screeners in small batches to avoid eye fatigue, and it's really important as a group of radiologists to agree upon a threshold from your recall from which to go straight from DVT to ultrasound, because for some, a 6 millimeter mass is too small, especially in a fatty breast. So overall, it was a really positive experience. Our techs, once they got used to the system, they loved the touch screens. They thought the machine was great, all the technology, the easier QC, the procedure times went down. Our patients really didn't notice any sort of difference. They felt more confident because they knew they had the new technology. There was some patient concern about increased costs and increased radiation, initially especially. And our radiologists struggled with longer interpretation times, but quickly adapted and saw the benefits, especially in the diagnostic and screening settings. There are many days that go by that a patient has a 2D mammogram and I say to myself, oh, I wish we had a tomo. I wish this patient let us do a tomo because I would know what this is. And tomosynthesis guided biopsies have actually really expedited our biopsy procedure and cut it about in half. So in summary, we've got a lot of great things going on. There's a lot to think about when you're thinking about implementing this new technology, but it has the potential to shift your practice away from diagnostic imaging workup towards a higher volume of screening. And so by detecting more of these invasive occult cancers, there's a higher likelihood that down the road we'll show that breast cancer mortality and morbidity rates have improved because of this technology. We haven't proved it yet, but I'm optimistic that we will. And with decreased false positives, DBT addresses one of the major arguments that's posed against screening mammography, which I think Jill's planning to talk about next.